Hello, everyone, and thank you for joining us today. My name is Paul Arangua, and I'm the Director of Research at the Prostate Conditions Education Council. It's a pleasure to welcome you to today's webinar, Biomarkers in Prostate Cancer, a Guide to Personalized Care. We are honored to have Dr. Neal Shore with Atlantic Urology Specialists and the Director of the Carolina Urologic Research Center. Dr. Shore is an internationally recognized expert on prostate cancer germline and genomic testing and will discuss the critical role of biomarker testing in the management of patients with prostate cancer. Biomarker testing is transforming how we approach diagnosis, treatment, and overall family health, offering more personalized and effective care strategies for patients. Today's discussion will provide insights into how biomarker testing is shaping the future of prostate cancer management and what it means for patients, caregivers, and healthcare providers. We appreciate your time and we look forward to an informative session. Now, let's get started.
Well, thanks very much. It's always a great pleasure to do work with the PCEC, also known as the Prostate Conditions Education Council. This is an organization that's done incredible work in not only educating patients and their families and physicians on all aspects of prostate cancer, but it's really focused a lot on the diagnosis and on the importance of understanding biomarkers. And we've learned a lot over the years, from prostate specific antigen PSA to, many more things. That's what I'm going to address today. And before I keep, speaking, I'm just going to tell you this right now. If you get anything from this talk, is that there is a terrible underutilization in the United States of genetic markers, despite the fact that there's the best level of evidence to be getting them. We mostly see that centers of excellence in the community and in tertiary and academic centers are using these genetic markers that I'm going to talk to you about today. So I hope what you get out of this talk today is that if you have prostate cancer, that you talk to your physician, your urologist, your medical oncologist, your radiation oncologist, and say, hey, doctor, I learned about genetic markers as a form of a biomarker. Can you tell me why we haven't ordered it yet? And if we have, what were my results? So it's a real pleasure. You see the goal today, and it not only affects you if you have prostate cancer, because it could impact FDA approved therapies today for specific genetic alterations that only apply if you have a specific biomarker genetic alteration. It can impact your family members, your children, your nieces, nephews, and your siblings. It can allow you to be part of clinical trials. So I really implore you to understand why this is important. And by the way, it's not just in prostate cancer, it's in male and female breast cancer, ovarian cancer, endometrial cancer, pancreatic cancer, other cancers as well. So we're all unique. We all have our own biologic makeup, our own unique genetic code, and the markers that can be released by tumors or cancer tissue are unique too. And they can give us these clues to not only the aggressiveness or the lack of aggressiveness of our cancer, but they can tell us about approved therapies and clinical trials, and also inform us about our family members who may need to be tested as well. And so we look at these biomarkers with parts of the DNA, or what's called the helix. There are other aspects of molecules, metabolites, proteins, RNA. It's a really fascinating and really remarkably cool area of ongoing research. But it's not just research. There's actionable, or what we just say is clinical utility from this information. So all these different biomarkers, virtually every lab test is a biomarker. And there's different ways and different things. You can get the complete blood count the CBC, the complete metabolic profile, your electrolytes, your kidney function, your blood sugar, your liver functions. But then we have these other markers that can tell us, are we at risk for cancer? Predictive, meaning if I have a certain marker, it's going to say if I will respond to a therapy. Prognostic marker, a marker that would say, you're going to respond to this therapy and it may increase your life expectancy. And we can use certain markers now in the bloodstream through simple blood-based testing to tell us how we're responding to therapies. That's really, really important. And so we're making great strides. And as was said in the introduction, it may not be for everybody, but for many of us, it personalizes therapy. We get more precision-based therapy. We can tailor the therapy to the individual. And it's not any longer as it really was when I was in medical school and right in the early parts of my career, where it was sort of always a one size fits all. So that's what's really fascinating about all of this. Now, personalized treatments, as I just said. So you look at all these men theoretically who could have prostate cancer, but having a certain marker may tell you which in that group of all these men with prostate cancer, because we have our own unique fingerprint, like everyone's fingerprint's different, your cancers are different. All cancers are not the same. I wish I had a nickel for every patient who came into me and said, my friend, he had prostate cancer and he had this therapy and he did really well. Well, that's your friend. And even if he matched up identically to your stage and all your other health concerns, or what we sometimes call the comorbidities, he may respond really well to that therapy, but you may not. And so that's really what this slide is trying to tell us. And so we're getting imaging tests. And in some ways, imaging can be a marker, a biomarker, lab-based testing, urine-based testing, tissue-based testing. It's a truly remarkable time, but it's very important to be aware of that. And the physicians who treat you, the healthcare providers, whether it's a urologist, a medical oncologist, a radiation oncologist, that they understand and they're ordering testing. So it goes under the sort of rubric of, knowledge is power. So let's break down. I'm really going to focus now on genetic testing. And, in healthcare and in medicine, we use a lot of long words and they can be confusing. But I always think it's really helpful to sort of simplify things. So germline, another word for germline is what you inherited from your mother and father. When you're a zygote in utero, which leads to the embryo, you're getting, DNA, half of it from the egg, the female partner, and half of it from the sperm, the male partner. And that is what contributes to the genes that you inherit, or hereditary genetics alterations. And sometimes you can inherit a genetic alteration from your mother or your father, occasionally both. Now, let me focus on this germline side, and we'll get to the somatic. You can get testing. It's really simple, from a blood-based test or from the cells along in the mouth, the buccal mucosa, or just saliva, what some people call a spit test. So you can get a home-based kit and you with just saliva or spit and send that out. Or you can get germline testing from a simple blood-based test. It detects the mutations that you get from your mom and dad, the ova and the sperm, the egg and the sperm. And if you have a certain genetic alteration, the one that people hear the most about is highlighted here, the BRCA, which stands for breast cancer gene. Now, men can have a BRCA alteration, and women can have BRCA. So it's a little bit of a misleading calling it breast cancer gene. Most of us will just call it now BRCA or BRCA. But there are malignancies that if you have a BRCA alteration that you've inherited from your mom or dad, it predisposes you to breast, ovarian, colorectal, prostate, pancreatic cancer. So if you have this blood-based test or saliva-based test, the germline, you could, and you're positive, which is, it's the minority of patients who are, most aren't. So if you're negative, you can have a sense of relief, but if you're positive, it can inform you about therapies that are approved today by the FDA for advanced prostate cancer. But very importantly, it tells you that your family members, your son, your daughter, your nieces, nephews, your siblings should be tested, because you can pick up an earlier cancer. It could be prostate, it could be breast, ovarian, endometrial, pancreatic. So really, really important for the health of your family members. Somatic, another word for somatic, what some people say, is the actual tumor tissue. And so you can test that through the actual biopsy of your prostate, or if you had your prostate removed, that tumor tissue, and it detects the tumor cells that drive cancer growth. Now, if you don't have the tumor tissue available, or it somehow, you moved, or you can't find it, or maybe it wasn't preserved adequately, you can do a blood-based test that will analyze the DNA genetic alterations that are in your blood. So it's a simple blood test. And again, if this helps you see if you have a certain alteration that would allow you to get a treatment, especially if you have advanced disease, meaning the disease that's outside the prostate and now has spread, or what we frequently call metastasized. Now, not everybody will have this, but if you do, it gives you the ability to personalize. Now, it's really important that if you do a germline and that's negative and you've got metastatic cancer, you don't stop there if your germline's negative, because if you did, 50% of the time when you tested for somatic, you'd find alterations that weren't picked up with germline. That's really important. So being negative on the germline doesn't mean you don't get a somatic, because you'll pick up another 50% of positive findings. So we have a paper that's going to be coming out soon in the journal called Urology. Some people call it the Gold Journal. Really proud to be part of it. It's been accepted for publication. It should be coming out in the next several weeks. I really encourage you to read this. This was thanks to great support by the folks at PCEC. The authors that you see listed here, many of them are great, hardworking folks at PCEC, but many are also urologists and medical oncologists in the community and in academic centers all over the United States. So I'm very proud that this will be coming out shortly. So what are the steps? And this isn't meant to be overly confusing. And, you start at the bottom. It's important to someone to sit down with the patient and family member and say, well, why are we getting the testing? And right away, it's because if you're positive, there's real actionable things you can do, or what we call, there's clinical utility. There's therapies that we can prescribe that are Medicare commercially approved that could benefit you. Not everybody, but some. It's simple to obtain a blood test or a tissue specimen. Sometimes we'll work with our radiology colleagues, and we'll do a interventional radiologist to just do a little needle biopsy of a lymph node or a lesion, and that could be helpful too. We get the testing, we get the analysis, the report comes back. It's important that your healthcare provider reviews with you what the findings are. Is there something positive, or oftentimes what we call a positive or a pathogenic variant, or there's really nothing actionable? There were no findings. Sometimes we have these things that are called VUS, or a variant of uncertain significance of VUS. Those are not necessarily actionable, but over time we learn more from large registries, and a VUS could become actionable, meaning that we realize after learning more, because this whole world of genetic analysis has really been just exploding over the last 20, 30 years. We keep learning more about certain of these sort of intermediary VUSs that could become pathogenic, or in other words, actionable. So at the end of the day, you go from the pre-test counseling to the testing, the post-testing. The GC that you see up here, HCP stands for healthcare professional. GC stands for genetic counselor. Now, if you can have a certified genetic counselor review things with you, I think that's fabulous. But we really haven't, we don't have that many certified genetic counselors. So it's important that your healthcare provider, if he or she doesn't have access or you can't get in to see one, because there's only a couple of thousand for our country of 300 plus million people, that your healthcare provider, you can ask him or her, but also there are telemedicine approaches where you can contact the company, and almost all of the companies, whether they're offering germline or somatic testing, they have someone who will talk to you invariably at no cost to explain to you the significance of your reports. And sometimes they're a little bit befuddling because there's a lot of letters and acronyms. But at the end of the day, it can all be explained. And I think that's the most important thing. So I already started to talk about this. You could have a negative result, meaning that, hey, and it provide you with reassurance. We don't see any genetic alterations that you've inherited. That's the germline. So you're not at risk of any of the hereditary cancer syndromes. Or you can have a negative test on the somatic, on the tumor side. So we don't have any drugs right now that we have approved, but we could have clinical trials. Now, you also have the VUS. And I told you about that, the variant of uncertain significance. And these are, it says over here, they're not clearly understood, and that's accurate, but they could change over the years as we get more data collection, especially in populations that haven't been adequately represented. Typically, some African American populations for sure, and different groups within the African American population, and Asian populations, and Latino, because a lot of the work has largely been done in white European studies. But we're even learning in that group as well. So a positive result, or what we sometimes call a pathogenic variant, a positive result, could inform us about new trials that are being offered in specific targeted therapies, that mechanisms of action are geared towards a specific genetic alteration. It can inform us about what to do if you have disease recurrence after your prostate removal or radiation therapy. So it allows us to, potentially have a more intensive initial plan. It allows us to be adaptive if you have recurrence of disease. It's all good in that it gives you more optionality. So I talked about this earlier, and I can't stress the importance enough about this. It's so many families have a lot of cancer in their families, and a lot of times we've realized that it's important to get a really good family history. So if a patient has prostate cancer, the clinician should not be just saying, well, does anybody else in your family have prostate cancer? He or she should be saying, well, do you have any other cancer in the family? And so these are one of these sort of pedigrees that get, developed. And this is where a genetic counselor can be helpful if you have one. It's great. You can do telemedicine with the companies, but it allows you to try to understand, oh gosh, if I've got prostate cancer, maybe I can find my son or daughter would have one of these alterations. I talked about the breast cancer gene or the BRCA, and we can diagnose them early. Cancer cures are most effective when it's localized to the organ, right? When it's metastatic, we're playing catch up. So GINA is the Genetics Information Non-Discrimination Act. It's a federal law that protects against genetic discrimination in the workplace and in one's health insurance. And I'm not an expert on this law, but one should really never see discrimination because of having a genetic alteration, and therefore it shouldn't affect your healthcare coverage or your employment. So it's very important to understand that. So let's talk a little bit more about the benefits of testing, some of the myths and some of the facts. Well, first of all, biomarker testing is only for advanced cancer. That's a myth. More and more we see in the guidelines that high risk, aggressive, localized disease absolutely needs testing. We're working on publications that are out there and presentations to sort of universalize or democratize so that everyone with prostate cancer gets tested, much like in breast cancer and in pancreatic cancer, endometrial cancer, and ovarian cancer. Biomarker testing isn't covered by insurance. Medicare will cover, and the overwhelming majority of commercial insurances cover germline testing. Biomarker results aren't helpful. They're clearly helpful. That's what this whole presentation is about and why you need to get tested. The facts to the right, it's valuable at all stages, early stage, advanced stage. I talked about insurance. It's absolutely valuable, especially to find personalization, tailored therapy, predictive, prognostic, clinical trials as well, and helping your other family members. So it's really important to have, the key questions and open communication prior to doing the testing. Why are we ordering it? How will this change my treatment plan? What happens if I find a mutation? The answer is it just opens up options for you. After I get the options, well, what does it specifically mean for me? And what about my family members? Sometimes we call that cascade family testing. Very, very important. Can I get a genetic counselor? Can I get it remotely with telemedicine? Can I get one up front? Do I have one accessible? Maybe my HCP is extremely knowledgeable and he or she can answer all my questions, which more and more we're seeing that in the community setting. Do you need to be retested? The answer is, if you do germline testing and it's a good test, good representative company of bona fides quality, the answer is no. One germline test is all you need in a lifetime. Now, somatic, the tumor tissue itself can change over time, and we're learning a lot about serial testing. There are many resources out there to support your journey. Here's a great list. The PCEC, many other sites you see here. And you can go onto websites. That's where, the internet can be really helpful. There are expanded access programs. The germline is only a couple of $100. Now, that's still expensive for many people, but the somatic testing, as I said, is a little bit, it's more expensive, but it's usually covered, and there are expanded access programs. There are support services with organizations like PCEC and other really great organizations, counseling services. You just really want to get tested. You don't want to be an ostrich. You really want to know what's going on. So there's many different companies. I use all of these companies and then some. It's not to say that you could have to use many of them. I have, because I wanted to understand how these different companies write their reports, but there's lots of ones in the germline world. You see them listed there. And in the somatic world, there's more than just you see listed here. There are other tests that are done called genomic tests. And the ones that you see here are not to be confused with genetic testing. These tests aren't telling you about alterations per se that you have inherited or the tumor itself. These are more about risk stratifying. Do I need to be biopsied or not? Or what's the likelihood that I need to do other therapies? They're good tests, and I don't want to confuse you. But if you had those tests under the heading of genomic and you said, oh, yeah, I got genetic testing, the answer is you didn't. These tests are very good, and I've used all of them, but they're helpful in informing you about, do I need a biopsy or not? And if I have a prostate cancer, do I need more intensive therapy or less intensive therapy? So in summary, it's super important to get biomarker testing. And it's super important not only for the individual patient with prostate cancer, but for your overall family health. You see the sort of steps here. These are these biologic molecules, blood-based, saliva-based, sometimes and tissue-based, so that it's accessible. And it'll help personalize your treatment. We have multiple FDA-approved therapies. More are coming. We're doing that research. This is not if you're going to get tested, it's when are you going to get tested? And my advice is sooner rather than later. there's these different changes that can emanate from what you inherited, germline, and from the tumor tissue itself. The GINA Act prevents discrimination, and it's important to talk openly with your healthcare provider and your family members, because if you haven't been tested, you should be getting tested, and you should also have that conversation with your family members. Most of these germline companies, if you're positive for a test, they'll usually test your family members for almost nothing, or only a couple of dollars. It's they're very good about that, and they'll give the telemedicine information. So let me finish up here with you can have these prostateconditions.org. There's the 800-866 number, the website. Just really great. There's just so much good information that's out there. So it's been a pleasure to speak with everybody today. I wish you great success. And there's always some stresses involved with a cancer diagnosis, but we have a lot of great information out there to help you battle and confront it with your HCPs and your family members. So thanks very much.